very honored to be able to do it. So what we are talking about is CPC Plus, and on the next slide, it kind of defines the three roles that we have in CPC Plus. We also, as I'll explain in a minute, we also led the project with regard to what now a lot of people refer to as CPC Classic, the first 7-region initiative, but then expanded in Ohio, and we'll talk about that in a minute. But our role here is three things. One is actually helping practices transform. So we have a fair number of practice facilitators, and this work is supported by and funded by CMMI, along with the other payers, as many of you know. But we do the learning and diffusion, the practice transformation work is something that we also, that we do. And then kind of growing out of that, when we first started doing that type of work, and it was part of the memorandum of understanding of all of the payers with CMMI that were participating, is that they would provide the practices with information, with data, and as to how they were doing. Well, within the first year of CPC Classic, we got alarm bells going off within the practices, and they said, you know, whoa, time out. We can't handle 9 different reports from 9 different payers and expect to make any sense out of it. So from that grew out a need and and our role as aggregating that claims data and doing some analytics with that and trying to put it into a unified tool that the practices could look at their comprehensive report of across all their payers. And then a third role that we had more explicitly in CPC Classic, but now kind of more of an aside, is to be involved with the payers and convene the payers. And to that end, we have been, it kind of goes without saying that if we're going to be aggregating the data of all the payers, we need to meet with the payers pretty regularly anyway. And many of you on the phone, I think, probably are aware of that on the call. But we are also bringing those folks together into where the payers sit together and talk about some of the things. And we had that most recently at our last learning session a few weeks ago. So that gives you a little bit of a feel for what we do within the Health Collaborative and where we connect the dots, if you will. So let's talk a little bit about the classic data, because I think we're far enough out that we actually can draw some lessons from it. And on the next slide, if you don't remember, Cincinnati was one of 7 sites chosen nationally by CMMI. It involved 75 practices in the greater Cincinnati-Dayton area. And we had 9 payers involved in the project. I think one of the most, if not the most, payers of any of the 7 regions. So we kind of got into it very early on with regard to how we bring payers together and how we make this thing work. And to do that, and also then it represents about 500,000 lives that we were involved with. So what we did with that group is that we ended up in our data aggregation being able to put together some information about how that 4-year project worked. And one of the things that we struggled with always was the rather intensive report and very well-resourced analysis that Mathematica was doing, because they kept coming out with reports on an annual basis that really didn't seem to jive with what we were seeing on the ground and what we were seeing in our own data. And it really, it should have dawned on us sooner, but what finally dawned on us was that they were looking at the Medicare fee-for-service data, and we had not used our data to drill down into how any one individual payer did in this particular project. And when we did do that, it was somewhat surprising. And on the next slide, what you'll see is that we, just across 4 different metrics, and then if you look, and many of you, I think, saw the write-up that Mathematica did in Health Affairs in the June issue. What they said and their conclusion was is that that the project did not meet its it did not cover the care management fee costs, and it just only it was statistically significant, but wasn't a very big improvement in quality. So what we thought was, well, hey, that's not what we saw. That's not the direction that we had, or that's not what we saw in the multi-payer data. So we broke it down, as you see in this table, and we said, okay, let's look. We couldn't identify any one individual payer's, including CMS's performance. So we had to do some grouping of data. So we did the grouping of the all government group, which included primarily Medicare fee-for-service, but it also included some of the Medicaid players that were at the table with us. So you couldn't really tell you how CMS did or any one of those payers did, but we actually saw similar results that they reported in Health Affairs, and that is that in inpatient discharges and ED visits and in total cost, we did not see really much movement at all. That 16% reduction in ambulatory sensitive conditions was not statistically significant, even though we had thought maybe, well, we're starting to see something there. But we didn't, and at least it didn't prove to be a statistically significant difference. So we thought, wow, that's interesting. So in the government, in the Medicaid and the Medicare fee-for-service populations, the most vulnerable populations, we did not see any movement, and we essentially confirmed what they found in the Mathematica report. But then we looked at the Medicare Advantage population, and there we saw quite a difference. And in fact, that was the population that had the most benefit from this approach, and that figure of a 63% reduction in ambulatory sensitive conditions we found rather astounding, actually. And that if you follow along the Medicare Advantage, you'll see that we ended up having rather significant results in all four metrics, even a 37% reduction in cost. I stop and pause for a minute because none of this is just a before and after picture. We did not have control groups like Mathematica did. We did not do the matching. You have to take all of this data with a grain of salt in the sense that it wasn't built to be a research study, if you will. So we did not take in all the various other market factors that were going on, and we did not do anything to say, okay, how much of that inpatient discharges was due to other market factors. However, when you stop and think about ambulatory sensitive conditions, those 12 chronic diseases, the PQI-90 metric, if you're for those of you who are metric savvy, those are 12 chronic conditions that are very common in primary care practices, and the admissions for those conditions went down to that degree. I can't think of very many market forces going on that would selectively reduce ambulatory sensitive conditions to that degree. The only way I know to reduce admissions for that population is to control their disease better. The only way you keep a diabetic from being readmitted, or a patient with CHF or a patient with COPD, is that you really end up having this, you think, whoa, well, wait a minute, that is pretty significant. And so I think based on that, I think there is some indication of where it's going. Yes, it wasn't a research controlled study, but it did the magnitude of the response, and kind of that the thing I hang on to is that ambulatory sensitive condition. So let's talk about the commercial. In the commercial population, we saw similar types of reductions in those ambulatory sensitive condition admissions. We saw it in inpatient discharges, and we saw it in ED visits, but we did not see any reduction in cost. In fact, that was flat. One of the things that we have to stop and think about, and what we didn't account for in these metrics, was adjusting for the automatic price increases that occur within the market, especially in the commercial realm. When I used to work for United, it was automatically assumed that there would be an increase every year in price. it just was a matter of how much of an increase. And I don't think I have to explain that to a lot of people on the call, but in this market, on average, across all payers, there was about a 5% increase each year in the price per utilization that they paid. So we would have to have overcome that 5% per year increase in order to show any cost reduction, if you will. So as my old boss at United Healthcare used to say, if you give me flat cost and improvement in quality, that's a big time success. I didn't have any increase, if you will. So we thought, this was really worth talking about and making sure that people understood what we were trying to do. And I think that's, and the thing that it spoke to me is that what's the difference in these populations? Why would one respond better than the other? And again, after thinking about it for a while, obviously the one thing is that the government group, the Medicare fee-for-service, is by definition a vulnerable group. They are not as socioeconomically well off as the other two populations, and they are going to be more affected by social determinants of health. So I think in many ways, we feel very fortunate that going forward in CPC Plus, we are able to now incorporate social determinants of health as a measurement factor in these populations. And to the degree that we can impact those, can we make these other, can we make their metrics move, if you will, if we address those issues? But certainly we wanted to make sure that the commercial payers and those that have Medicare Advantage lines of business understood that even though they came out with their analysis in June, there is another side of the story, and that it's important for people to understand how different populations respond. I should mention that we have submitted this information and a kind of a write-up for this, and it has been accepted by Health Affairs on their blog. It does, like I've said before, it does not reach the level of a research, so it doesn't really deserve something as a write-up as a research. We shouldn't make that fit that way. But as a blog piece, it is an interesting piece of information that she needs to be taken, and that should be appearing on their blog, I would think within a few weeks, but it's been accepted for that. And the thing that will be about that blog is that it will have a link to our website where a lot more detail into this data can be obtained and more, slices of how we looked at it. One of the things that we did on the next slide, just to give you a feel for this, and again, I say this because I want to make sure that payers understand that this doesn't happen immediately, and we're seeing the same thing in CPC Plus, but that it does take, and we did not see these reductions and these improvements in this until after the second year of the report. So it wasn't until the third, in fact, it was about 18 months to 24 months. And for those payers who are involved in our CPC Plus, they know this very well. But that's how so expecting this to show up year one is not reasonable. And it is something that takes time for it to develop. In the next slide, we talk a little bit about, I need the next slide, Lisa. There you go. All right. Some of the lessons that we learned from this, and I did a fair amount of interviews, both payers and physicians. So this is kind of getting into the multi-stakeholders that were involved in this had different angles as well that they saw. So most of the payers that I talked to, I didn't get to all of them. Some of them are better at data collection than others, but they confirmed that they saw significant quality of care improvement, and with their metrics and with the things that they had been following with regard to quality. And some of that was directly from the practices. So they could vouch for some improvement in hypertension or some improvement in diabetes control. They also felt the timing of this was important. They had already committed to a value-based payment model. And what this did was kind of reinforce those programs that they already had in play. So it wasn't necessarily a one-off. It was something that they could incorporate into their business approach going forward. And the thing that they really liked was that in taking a multi-payer approach, it wasn't them out there just trying to get it done or trying to convert practices to going across this methodology. That as a multi-payer approach, and this is where CMMI I think really deserves a lot of credit, is that they were able to have a mechanism that they could bring more payers to the table to give those practices the critical mass they needed in order to make this a reality. They also found that the funds that they spent on care management, and to tell you the truth, I was quite surprised and shocked when I went to work for United Healthcare and saw their budget for what they spent on care management. And I found out that that's not just unique. All health plans are very interested in care management, mainly because they see that's where utilization gets driven. The problem with it is that as payers, it's very difficult for them to connect with their membership in a care management venue. There are trust issues, there are, I don't want to be bothered issues and so forth. But I think that what they found very effective in this was that by having the practices now participating in this with them, they could divert some of that care management resources to the practices or help support the practices in care management, and it was much more effective. It was coming from a trusted source. The primary care office was a place that they could connect with their membership. And the other lesson or thing that they found very helpful about the whole project was to demonstrate that to their large self-funded customers that the investment was better than break even. And while not reducing quality, and in fact, while improving quality, it also was better than break even. And it was a good tool to help them be able to take information, evidence, if you will, out to their self-funded customers to get their buy-in into it, to the degree that some of the health plans made participation in these types of efforts a standard operating procedure for their self-funded customers, which I think also was quite helpful. So on the next slide, I think switching over to the physician survey, as a primary care physician myself, and having been in solo practice, I wanted to give it the reality test with the practices, because I definitely didn't want to make their job harder. And one of the things that's always kind of driven me in my career once I left private practice was to see what we could do to improve the plight of the primary care physician. I was very impressed. Of the about 25 physicians that I interviewed, not a single one said that they wanted to go back to straight fee-for-service payment. That kind of blew me away. I said, really? All of them, to a person, said this is better than what we were doing under fee-for-service. Again, I didn't do a research survey. I didn't do all the things that you need to do to make this research worthy, but I'm just giving you the feedback when I went out and asked the question. Interestingly, they really liked the increased professional satisfaction from providing comprehensive care management to their patients. They felt as though their time, even though it wasn't reduced, was better spent. They felt like what they were doing was really what they went to medical school to figure out how to do, and that now they could do it. They were actually diverting their energy to the things that they really felt expert in and that they felt that the patients really needed. They concurred that it was a 2 to 3 year learning curve. They felt like, in fact, when I went out and showed them the results that we had from just the first 3 years, they said, well, wait till you see the 4th year. And I said, what do you mean? And they said, hey, in the 4th year, we were just hitting our stride. And indeed, I didn't show it here, but in the 3rd year, those savings, those reductions in admissions and so forth, were about 25 to 30% less than what they were after the 4th year. It really blossomed in that 4th year. And it was true. I mean, all of them said we were just hitting our stride, and they actually had their team working and firing on all cylinders. And then, interestingly enough, even though we hear a lot about payment of primary care physicians, being low man on the totem pole and not getting the funding that they really need to have, it was not the thing that was driving them. And in fact, the quote that I put there at the bottom, if the non-financial advantages has not been realized, those other things I just mentioned, they said the pay alone would have been insufficient. It wouldn't have helped them go around. They felt as though it was the other things that were more important. Yes, it can't be done without the payment. Yes, you do need to have enough money to pay a care manager to take that load and to be able to do the things that need to get done. But it really, in some ways, they felt fortunate that the program paid attention to certain milestones they needed to accomplish. Because if they were just given a blank check, to say, so to speak, and say, hey, here's more money, do what you think you need to do in order to improve the outcome, many of them would have been at a loss. And so they said that, having that guidance, even though it was burdensome, even though there was probably more requirement and milestones than needed to be, it wasn't a bad first start to just say, yeah, you really need to pay attention to stratifying your patients and tending to those sicker ones, et cetera. So that's, so I was very pleased when I went out and got the physician feedback on that. And on the next slide, I think we look going forward into CPC Plus. So what we have now is an opportunity to really expand the approach to this. And so we're going from 75 practices to 560, from about 500 providers to 2,600. Actually, I think it's 250 providers to 2,600. From 11 payers to 14 payers. The 2.5 million patients. And in fact, if you do the math and the back of the envelope calculation, the number of patients that are actually going to those practices is closer to double that. It's about 5 million of a population that are going to a CPC Plus practice. They're only getting care management fees for about half of them, for about 2.5 million. So it is, but the 2.5 million are the ones we can measure. But stop and think about it. There's only about 11 million people in the state of Ohio. So about half the state is receiving its care in this kind of a practice. So in the next slide, it tells you which payers are involved, or I should say which payers are involved in giving us their claims data. There are 14 payers. There's only 11 listed here. We have Ohio Medicaid as its own entity, which is a small amount of the Medicaid claims has not yet participated. And there are 2 very small plans that have, actually one doesn't have any lives yet in the state. They're out there selling, and another one that also is very small. The 4 that you see at the bottom, as well as United Healthcare, have the contracts for Medicaid in the state. United Healthcare is also contributing its commercial and as well as Medicare Advantage and the other payers. And we also have, obviously, CMS. So we have, if you take all of these payers together, it represents about 93%. Actually, not that much, probably 85% of the claims in the state or the care being delivered in the state. I may have to take that back because I haven't recalculated it with a couple of other recent changes in the payer mix. But anyway, it's a significant proportion, and it's a great opportunity. It's an opportunity for us to do more in the way of analyzing what it is that this project has accomplished. Because if we hadn't been doing the data aggregation for CPC Classic, I don't know that people wouldn't have walked away with the Mathematica evaluation in mind and said, I guess it didn't work. But yet it did work, or at least it appears to be working based on the results that we're getting from other payer data. And I think this is really kind of underscores the need to do a multi-payer perspective, to be able to make sure that you're looking at the different populations, because they do have different abilities to respond to the efforts. So what we did was we actually have already begun to do some analysis of CPC Plus. So I'll share a little bit of that with you in the next slide. What we said was, okay, we've got these people, these practices, those 75 practices that have been through this and showed good results, and you see them on the right side of the screen. And this happens to be one of the metrics that they're supposed to get, and that is the emergency department follow-up within 1 week. And you can see that they are maintaining that performance. They are doing quite well and have, so the learning that they've done, the process they put in place, it is sustainable. It is something that is not just a flash in the pan. It is something that once the practice converts, they seem to maintain their ability and skill set to do that. On the left are all of the 560 practices, including the CPC Classic practices. And you can see that in this particular metric, they are approaching the average across all CPC Plus regions of the 18 in the project. And you can see from quarter to quarter that they're staying relatively flat, not yet making much progress. And again, it takes 1.5 years to 2 years to really see, for them to, the teams to form and for them to make some improvement. In the middle, you see the practices in Southwest Ohio, where we did our original CPC Classic. And the majority of the practices in Southwest Ohio that came on to CPC Plus were the other half of the practices that were in those systems that were in CPC Classic. So almost all 3 or 4 of the adult systems in our region had half of their their primary care practices in CPC Classic. Come CPC Plus, they included the other half, okay? And so you can see that the learning curve and the results are showing some more stair-stepping and a tendency upward. And we think it's because of the peer-to-peer and obviously being affiliated with systems where they can put it into play quicker. And in the next slide, we do a similar type of metric, and I'm not going to spend a lot of time on it, but actually it's the more important one. That is follow-up from a hospital discharge within 72 hours. And you see the same patterns going on. CPC Classics, our practices are doing it quite well, and that compared to all practices, and that we see the same, being in the same systems, being in the same territory helps the learning. So what we did was we said, okay, that's how they're doing on their milestones. CPC Classic practices continue to do a good job of that. So how are they doing in their results? So we looked at their multi-payer data in the next slide, and you see that, and here I just, I changed the breakup, or the grouping a little bit. It's a commercial versus all Medicare, including Medicare Advantage, which remember was the one that did the most. So you have to kind of average that out, if you will, between the two. And some of it's going to depend upon the preponderance of one population versus the other. But in the, let's just go down the commercial line. So all practices within CPC Plus region for ambulatory sensitive condition admissions and for ED visits, those first 2 highlighted bars, a 12% reduction and a 5.4% increase in ED visits. Not much change. We didn't do the statistical analysis, but again, we're not seeing it take off as quickly. In the South, and I'm not going to, you can see the numbers for yourself that it goes up, but just look at the CPC Classic practices. So even on top of the performance that they had at the end of CPC Classic, they're seeing an additional 36% reduction in ambulatory sensitive condition admissions. That's rather amazing. Again, we don't have the control groups. I'm actually in the process of trying to develop control groups going forward at CPC Plus, so we can do more of the research level of work on this. But I think, again, the magnitude of that is impressive. And then also the fact that we're seeing it also in Medicare and Medicare Advantage. That's probably an average of a very responsive population, a not so responsive population. And then you also see in the ED visits, we're making an impact into the commercial ED visits in those CPC Classic practices. So to me, this is reassuring that some of the improvement in skill sets or care management that we think should have an impact on our results are proportional to the results that we see. So again, gives me some confidence that what we're seeing is real, even if I can't, show at the level of a research study. So it's a good place to be in. I think I have high hopes that CPC Plus will continue to show some continued improvement. So I want to make sure that I keep on schedule here. So I'm going to let's go to the next slide, and I'm going to kind of keep a few others in reserve, but I want to make sure I get feedback from folk, and we can talk about other things if we need to be. So why is it important? One of the things that is very important in my mind, when I went out and talked to both payers and practices, the first bullet you see there is what I had to have the light bulb go off or the paradigm shift happen with payers. Because what payers did was they said, okay, well, I gave them my data, I gave them the claims, and hey, they're not improving in my population, or I'm not seeing a result here or there, or based on my narrow slice of their practice, this is what we saw or didn't see. And I said, really, what do you want practices to do with data? It's not so much to demonstrate a movement in your particular population, is it? I mean, it's really to see what kind of information they need in order to manage their population. And they can't manage a United population different from an Anthem population, different from a Medicaid population, or you name the payer. They need to manage it all together. And in order for that to happen, they need to have that comprehensive view of their practice. So if you're feeding in data and you're just looking at your own data and you're not seeing the bigger picture of that practice, you're going to miss a good partnering practice because you're not seeing their overall performance. And that's one thing that I think payers begin to think, oh, okay, we need to make sure we look at that as an overall report. And if you could look at Medicare fee for service, or you could look at CMS, would be asking themselves the same question. They say, well, hey, this just didn't work because we didn't see the results in our payment, in our membership. Well, yeah, it did work. And guess what? If you just stay with it long enough, it probably will work for your population too, because the things that they're doing, the skill sets that they're learning, are making a difference in that population's outcomes. Switching to the practice side, the biggest hurdle that they had was understanding that it's a new game. That this is no longer, hey, if I need to meet my numbers this month, I just have to stay later and see more patients, or open up on Saturday, or as I used to do, take all comers. I got to see more and more people. I got to run faster on the treadmill in order to make my numbers and my budget. That's no longer going to work in a value-based payment arrangement. If 50% of your income is now value-based, and the fee for service is either going to stay the same or get smaller, your ability to react, your ability to affect your budget is now no longer going to be strictly under your control. You're going to need to be able to understand what value is, and whoever measures value is going to control payment. And when we talk to them about our approach to this, that not only do they reluctantly pay the data aggregation, they should really want to pay to be involved in the data aggregation. And many of the practices glommed onto that real quick. They said, if I pay to be involved in data aggregation, I'm now a co-owner of the process. If I'm a co-owner of the process, then I have a say-so in how that gets done, how it gets risk managed, how it gets presented. And that's really what we have found to be a very potent concept to get across to practices. And that's really where the business model came in. It's also what brings both payers and practices submitting the data that's there, since they're all involved in its calculation, can more readily accept it as the source of truth. Okay, there's no discovery.
Okay.
It does.
I
Reversible, yeah, that's
thought
nice.
that it did that. Okay.
We're getting a little bit of feedback.
Yeah, we are. Hi, can whoever just dialed in, please put
All right,
yourself on
goodbye.
mute.
Have a good one.
Lisa?
Say hello to
It just
Howard.
left it there.
All right.
Oh, sorry.
Okay, we'll keep going. So anyway, that and now, and that last bullet is just a little bit of like the proof of concept. Okay, why can we now publish results that has a multi-payer view and say, guess what? It does work. It is something that we can demonstrate. Proof may be too strong of a word because I still need to do the research. But to the degree that we're seeing some movement and some trends in the data, helps us demonstrate this to the satisfaction of payers and practices and the ultimate payer, the employer or the government, that something's going on here that makes a difference. So with that, I'm going to, let's go forward 2 slides. Yeah. The seat at the table, I've already talked about this, and being co-owners of the process. If any of the payers who have been participating in CPC Plus would like to sit in on one of our data work group meetings, it is an interesting conversation that goes on between payers and practices. And some of you who have their payers already on those calls probably already see that. But it is where this process gets worked out. On the next slide, what we take away from this and what the payers tell us is that if these reports or this data doesn't get used by the practices, then we're just wasting our time and wasting our money, and they're not interested in making a report that just sits on the shelf. They have too many of those. So what we are engaged in our work is to make sure that the practices have actionable data, that we're able to translate this into patient-specific, physician-specific performance so that performance can be impacted and changed and measured to see if indeed it's having an impact. So that's, and the other thing I would emphasize is that the reason practices really get involved with this is because we spend an awful lot of time on data coaching. And this is one thing that I realize is not necessarily scalable to a lot of other markets, but it really has helped us to have both the data, the practice transformation work and the data work in the same organization. We cross-train our practice facilitators that do the practice transformation work in the data that we're collecting. So now when they go out to do practice coaching, they have the practice's data to say, and make the best use of that data, if you will. All right. I think I'm going to stop there, Lisa, and see if there's any questions or discussion.
Great. Thank you, Dick. That was a wonderful presentation. Most of you are off mute. I did mute the most recent participant, and I'll allow that person to speak in a moment. But I'd like to open it up for questions or comments.
If there's any payers on the call that participated in our region with regard to CPC Classic, I'd really like to hear your take on this.
Yeah, that would be great. There are quite a few payers on the line. I'm just looking at here. I don't see anybody from Ohio in addition. Oh, okay, Monica is on the line from Medicaid in Ohio. Dick, maybe I can start with one question about the physician survey that you did. Mm-hmm. And were you using a series of structured questions, or how did you go about doing that? Because I know you spoke to a lot of people. I know that was a pretty lengthy process.
I did have a list of structured questions. I can't swear that I followed it all the time because I wanted it to be a discussion. And so I would start out with the questions, but sometimes it would take us in different directions, and we'd have conversations that didn't always come back to the. I didn't always get all the questions answered. Let's put it that way. So.
Great, thanks. And that's a very, I think that's just a really important part of getting a sense of what it's like for people to participate in this work. And I know Mathematica goes out and does a lot of interviews as well, but it's just one of those things that there can never be quite enough, I don't think.
Well, it was very helpful because this blog that was accepted by Health Affairs, Laura Sessums co-authored it with me. And she was one of the authors on the June issue, or the article from Mathematica. And her insights into all of that were very helpful. She helped me understand better even how much of a, Mathematica, I mean, it's their business, and they have considerable resources to do that evaluation, and they're very academically inclined, and it's a first-class study. But even with that, she was saying, we kind of shared back and forth, and I said, that's great for the government. They can do those kinds of studies, but in the business sense of in the business of doing a commercial health plan, which I had familiarity with, I said, that type of analysis, number one, it would take too long to have much impact on decisions that needed to be made today about where we were to go. And number two, to spend that much resource on just doing the studies would not necessarily be a good use of the company's money to go to that depth. And so it was an interesting contrast to say, okay, how much, when you do these types of studies, you do them for different purposes, and you need to be able to understand that as you look at the data. That also translated a little bit into something as simple as doing how far out do you do the claims run out. And I just had this discussion with CMS and with a couple of our other payers. The industry standard has always been a 90-day run out. Well, that's great if you're trying to compare your cost, and especially since that more complicated cases, that claim may not come in and within the first 30 days or 60 days, it might not come in until after into the 90-day. So and they have the tables that show you how complete your data is. And if you're trying to make decisions about cost, yeah, you're going to exclude some really high cost cases if you do the cutoff after 30 days. Well, that's not what the practices use this data for. They're looking at how much utilization did I have in the ED or in the inpatient. A high cost case still only represents one admission. So the data that I'm producing with a 30-day run out is still very valuable to the practices, because now they can get much quicker a sense of if what they're doing is having some impact. And that's also been a lesson learned that we took out of this, is that when you're talking about data and claims data and how it gets put together, it has different utilizations, and depending upon the utilization you want to use it for, you don't necessarily have to wait 6 months or a year to get the data. You can do it much quicker.
Dick.
Yeah, this is
go ahead.
This is Dr. John Weisel in Montana.
Yeah.
One of our challenges is always attributing patients to a practice, or even defining what a practice is. We know that cost shifting can easily happen if primary care just defers all the chronic care management to specialists. Mm-hmm. How do you address that issue?
So for attribution, all of the payers did their own attribution. And I can tell you that it was a wide range of accuracy on their attribution. The larger health plans, the national health plans, did it better on average. The smaller, more regional health plans struggled at it a lot. Most of them did do it based on PCP visit, but it was, and some algorithm visit, or in some of the more sophisticated cases, who wrote the last prescription. And that was something that the practices had a lot of heartburn over. They didn't like it, that it wasn't as accurate. But what we could show them with multi-payer data is that even if a particular payer wasn't doing it as well, over time, if you were seeing trends in your data, you could still make reasonable assumptions that something you were doing was improving your process or not, or your outcome. And so, yeah, it's not, it's that's actually a discussion that we had in our data work group is, okay, how good is good enough? We can't make it perfect, so can we make it good enough that you can learn something from this data? It gets different, though, when you're trying to do the evaluation. And if indeed we do get to a point where the payers use this multi-payer data to drive their incentives or pay for a performance, I think we will have to get much more. We will have to demand a certain level of accuracy from the health plans in their attribution. Is where I see us going. And so, if you don't meet 80% accuracy, then you're going to have to let us do the attribution for you.
Dick, this is Eric Muther. Great presentation, as always. And maybe you don't have the answer to this question, that's okay. But why does it take longer for government payers to benefit? I mean, do you think it's influence of social determinants of health, as you mentioned? Is it that the risk score, combined HCC scores of the fee-for-service patients are higher than the risk scores of the commercial patients? Is it something to do with benefit design? Fee-for-service Medicare patients don't have a PCP, and Medicare has a little less flexibility with benefit structuring and adjusting cost sharing. Do you have a sense of which of any of those may be contributing?
I think they all are. I would say that if I had to guess or estimate, I would say that social determinants are probably number one. I don't care how good of a primary care delivery method approach I give a patient. If they can't afford their electric bill, they still probably won't afford their medication. And so I think we're onto something as a society that social determinants are a big factor. I think the second most important factor is habit. And I think we have generated within our populations, especially the Medicaid population, that they may have a primary care doctor, but it's the ER that delivers 90% of their care. And it's almost, I think it is a habit. I think it may be convenience. I think it may be, there's a lot of different reasons why there's overutilization, I think, of the ER. But I think that's, so I think habit's a part of it. And I know that our care managers in the practices, when they were working with their Medicaid populations in this project, that's a much tougher habit to break. It's almost a social construct that that the patients have with regard to ED. I think the access is probably the third issue in my mind. I think access of these patients to primary care physicians. And I think that it is related to payment. I think it happens in Medicare fee-for-service as well as in Medicaid. And so they don't have the degree of choice of going to a provider or a primary care physician. I know when I was in private practice and many years ago, but I don't think it's changed a whole lot, I could only afford to see about 10% Medicaid. If I went much beyond that, it was, I couldn't make the budget work because payment for that population just wasn't sufficient to cover my costs. I think that is going to be a big issue in our small communities and in our rural areas. FQHCs have started to grow, and they have a different cost reimbursement methodology. I didn't get into it, but we also have what they actually call CPC Ohio. It's the state innovation model of how we're reaching out to our Medicaid populations who are payers in CPC Plus. And we're working out ways so we make those things work together. And we'll actually be getting the data on that as well, so we'll be able to evaluate that. But I would say those would be my top three on where, and if you got other candidates for it, I'd be interested.
Thank you. Any other questions right now? There's a couple things on the chat I thought I would share, just in case people are not able to see it. First of all, from Tricia Baird at Priority Health in Western Michigan, just a congratulations to you, Dick, not only on your progress, but on being able to document this improvement. And her statement is that asking a good question is the first step to a meaningful answer.
Yeah.
Your stakeholders are improving the health of the entire region. So thank you, Tricia, for those wonderful words. And then a question came asking you about the clinics or payers expressing any concern about the 30-day runout not matching HEDIS measurement specifications.
Yeah, in fact, the 16 measures that we did in CPC Classic, I think only 1 or 2 of them were HEDIS. Now that we're getting more into collecting the data in the Medicaid space, we've added about 7 HEDIS metrics. So we really haven't gotten into that at this point as far as the difference and the run out. One of the things that I think we're going to end up doing, and this is probably true for the Medicare as well as the Medicaid populations because they are so HEDIS metric dependent, is that I think we'll have different calculations of HEDIS metrics based on their use. So for a practice, a 30-day run out on their HEDIS metric is not meant to be their final score. It's meant to show them where they are in filling those gaps of getting those mammograms done or colonoscopies done or whatever the HEDIS metric might be. However, when we get to a point where it's okay, now a yearly evaluation of what it is, how did you perform on your HEDIS metric, that's when I think we'll need to comply with the HEDIS definition in the HEDIS runout so that we can make sure that we've captured their best data for them to present as their performance. That answered the question, or did that make sense to you?
So it makes sense to me. It was Lisa Miller who asked that question. Lisa, do you have a follow-up question for Dr. Shonk? Oh, no, she says it answers it. Great. Okay, thank you. We just have just a few moments left. Any further questions or comments for Dr. Shonk? So, Dick, I want to personally thank you for just all the work that you do in general, but also for your incredible generosity and skill in sharing this information with the group on the line today. We have recorded this, so this entire presentation will be available on our website probably by the end of this week. And I actually, while I have you on the phone, Dr. Shonk, would you be willing to, are you able to share these slides as a PDF format? Or if you need to check on that and get back to me, that's fine. Either way.
Let me check on it. When somebody accepts some of the data for a publication, you don't want to mess yourself up by releasing it.
Oh yeah, absolutely. So we'll wait on that, and I'll let the group know. Just as a reminder, there will not be a monthly webinar next month. It sort of falls in between the Christmas and New Year's holidays. So I decided to just cancel a December 2018 webinar. And our next one is at the end of January. And we're very excited to have some guests who will be talking about the collaborative care model. Once again, focusing on measurement of behavioral health integration and access in primary care settings. So look forward to that, and more information will be coming to you by email and by updates. Once again, Dick, thank you so much, and really appreciate everyone taking the time to be on this wonderful, wonderful webinar today. Thanks, everybody, and we'll see you.
Thank you.